Thanks for invitation to this interview. I'm Gun Jung, PGY2 pathology resident at University of Wisconsin Hospital.
My name is Mark. I'm a first-year resident at the University of Wisconsin.
Wei Zhang, and I'm assistant professor at UW Madison, focusing on molecular and GI pathology.
Thank you. So Gunyong, I know that you primarily took leadership in this project. Tell us about the opportunity that made you focus on this particular issue.
We know immuno-oncology, it's a very promising field. We also know it's a very dynamic field, which means everything is changing very fast. As a lab, we should provide a biomarker analysis and results. We decided to focus on PDL and IgC, which is the main biomarker in immuno-oncology. So far, there are several tumor groups which should be analyzed using PD-L1 IgC, but as I once mentioned, it's a very dynamic field. So we felt we should be more vigilant at this changing field. So our focus was how can we catch up those new guidelines or requirements from the immuno-oncology field. So we decided to focus on NCCN guidelines, which provides more up-to-date result, and many of the oncologists and other oncology-related physicians are following. So we just initiate this project and we search most main or general tumor groups, which is 16 tumor groups. If the guidelines provide PD-L1 IgC is required for each tumor groups, and we are summarizing those requirements to the table, and eventually we will share this result with our lab colleagues. And that we will be prepared to provide those results timely and more appropriately. It's our goal.
Thank you. Mark and Wei, what roles did you all have as you collected this information, as you created the tables?
So for me, primarily was learning from sign out when Dr. Zhang likes to use PD-L1 and which type of tumors it's appropriate. Right now, I would say my role right now is just making sure I understand why the project is being done, where it can be applied to in the future. And if I were to take more of a leadership role in this project, would be to understand where we could use it in the future, maybe amongst other immunomarkers, since it is such a rapidly changing field, like Gunyang said.
I, basically just supervise, and Gunyang did most of the job. As he mentioned, the main focus we're doing here is really because this field is evolving every day and the guidelines changing every day too. When and for which subspecialty, which tumor we should do PD-L1, which antibody we're using, whether we already or we can do them in-house, we need to send out is something we always confuse everybody. So, we are trying to get a universal guideline or a kind of cheat sheet for our faculty to have a basic idea what we do for each tumor, so we can share, and Kunyang and Mark will do their best to update it.
As you pulled the data together and reviewed the guidelines and created these tables, did you encounter challenges?
I've searched NCCN guidelines for each main tumor groups and try to find out if the guideline contains PD-L1, the term from the guidelines, but sometimes the term was inside some very end of this guideline, which means it was considered but not officially included in NCCN guideline. So at that time, I had to check the prescribing information from each medication.
What do you anticipate the future is going to look like either next year, in the next 6 months?
There could be several changes. For example, if a new tumor group such as pancreatic cancer or biliary cancer, they are not a main target of immuno-oncology, but if the pharmaceutical find it has some positive effect on those tumor groups, they could be included in the NCCN guideline, then we should be prepared for those groups. Also, we recognize that there are several alternative biomarkers such as MSI, MMR, or tumor mutation burden. As a pathology lab, we should be prepared for those updates, even for other biomarkers. So my conclusion is we should be prepared for new tumor groups, which required to assess PD-L1 IgC. Also, we should be prepared for some next or alternative tumor markers such as MMR or a tumor mutation burden or any other things could be possibility.
I think the future is having very directed, precise treatments for patients that otherwise wouldn't have had options. So what I've learned, for example, is if there is a certain cancer that is not normally treated with immune checkpoint inhibitor therapy, but has a lot of tumor mutation burden, they could be candidates for immune checkpoint inhibitor therapy. It's giving patients that otherwise had no opportunity to benefit from precise, up-to-date, and cutting-edge technology in precision oncology.
I think all of us has no doubt there more and more testing will come up. Whether we expand all tumors or some of tumors, we don't know. Actually, Kun Yang just mentioned we have 16, we selected to 16 common tumors that we see in our practice. And I think majority of them, maybe 10 of them are recommended for PD-L1 testing based on NCCN guideline. My expectation is it's going to expand to other tumors too, just when and how long. And it used to be we don't test that many cases. It's based on stage, everything. Now, I think we send out a lot of cases in-house. We're only doing upper GI and thoracic for PD-L1, but we are actually validate all other PD-L1 testing on other subspecialties. So it will definitely be broader, and in-house will make the turnaround time faster. That's definitely there. And, Kun Yang and Mark also mentioned that not only we know that it's not PD-L1, MMR testing, TMB are all indicator or all biomarkers we have been using for immunotherapy. On top of immunotherapy, there are a lot of target therapy can be broadly considered as maybe a pan set of pan cancer marker in the future too. So this project will extend it to different genes, different possible biomarkers to not only for immunotherapy, for target therapy, benefit cancer patient. That's the main goal, I think.
Gunyong, any other last comments you'd like to make?
I think we should adopt a digital pathology platform, and we should be prepared for those technology as well in the future.
I'm a molecular pathologist. I have, really passion for molecular. I think Kun Yang mentioned digital. That's definitely part of the future of pathology too. But my heart goes to molecular. So molecular and immunotherapy will go, it's already very, start kind of booming right now. It would definitely go further, and there more and more treatment will come out. So every year we know there's new approved drugs, new approved therapy, even just more immunotherapy, immune checkpoint markers. There's so many different, these drugs has been tested on different tumors. So, molecular is the future of pathology, and is the method of the way we can treat cancer patients, help the cancer patients. I have no doubt for that.
The potential too of this project is that it's very collaborative in nature. So while this is something that's limited to something we're doing in our group to kind of standardize the way that we approach antibody or IHC testing, I imagine if this expands to other antibodies and other cancers, that we could have collaborations with people from multiple institutions where we're sharing information more easily, and we're broadening the horizon of what we understand about the current treatments for difficult to treat cancers.